the way I organized this first talk is it's an excerpt from a course that Shirok Shariat and I gave at a EAU, actually the first EAU bladder cancer meeting this past summer, and we taught this for about 3 hours on variant histology. Some of the slides I've borrowed from that, and I've built it around 3 cases. I think that we're all pretty comfortable with conventional urothelial cancer. I think we're all comfortable with the fact that mixed histology is quite common. It's actually what makes the disease quite fascinating. And we're learning a lot about the molecular events that are associated with the so-called variant histology. But the clinical management can sometimes be a little tricky. Do I give neoadjuvant chemotherapy? Do I not? What kind of chemotherapy do I give? The proper local regional treatment, be it cystectomy or radiation. So these are my disclosures for this particular talk. None of these are relevant. I will point out in the next talk where my engagement with some of these companies overlaps with some aspects of the talk. Variant histology actually is quite common. In the TCGA data set, it ran at about 15%, and depending upon the study that you read, it can be as high as 25%, and it really requires the pathologist to have a fairly in-depth understanding of variant histology and what to look for under the microscope. And in fact, the AUA guidelines speak very specific to this. I did sit on the muscle invasive guidelines panel, and we felt very strongly that in the case of variant histology, you should have a GU pathologist review it to make sure that that's exactly what we're looking at. And you always want to identify the percent of variant histology because it could make a difference, and the EAU guidelines speak to this in a similar fashion. This is essentially a complete list of the urothelial cancer variants, squamous being the most common, adeno the next. There's a neuronal or neuroendocrine type. Micropapillary we're seeing a lot of, but it's actually quite common. But some of these are a bit rare that you may not run into them very frequently. If you look at the National Cancer Database, now we're looking at non-urothelial cancer. So this would be pure squamous, pure adeno, pure neuroendocrine. You can see that the pure histologic variants are relatively uncommon. Just so I get it out there, if you have a pure squamous, pure adeno, there's no role for cisplatin-based chemotherapy in those patients. And I think that most urologists are familiar with the adenocarcinoma of the urachus, and that's treated with a partial cystectomy. Just want to get that out there. These patients with non-urothelial tend to be younger, a little bit higher proportion of women, and I think part of that's related to the association of women in squamous cell cancer, more frequently muscle invasive and more frequently metastatic. So these are pretty aggressive tumors when you do encounter them. And in this multivariable Cox proportional hazards model, they are independently associated with a worse prognosis. So our first patient is a typical urology patient, 64 years old, gross hematuria, has some comorbidities, has good renal function, and has a mass that you can see there in the images on the right. Okay, there we go. Has a positive cytology and a fairly typical appearance of a papillary tumor. So this turns out to be a T1 high-grade cancer. Has focal CIS, and you'll see that in about 30% of the time. If you know going in that you've got a T1 tumor, I recommend doing site-directed biopsies because you can have CIS both adjacent and remote. Has a visually complete resection, detrusor in the specimen. You cannot accurately stage T1 without detrusor muscle in the specimen, but the kicker is 30% variant histology. And the reason that this is a kicker with micropapillary is there's data out there, or I should say modest level evidence and opinion-based, that they may or may not respond as well to BCG if BCG is the otherwise appropriate therapy, or they may not respond to neoadjuvant chemotherapy if they have a muscle invasive cancer. So very briefly, what would you do next? Re-review, verify the percentage of micropapillary. That's always a good idea. Would you go straight to intravesical therapy, re-TUR, or just go ahead and do a cystectomy? So who votes for one? Everybody has to vote, by the way. So Jeff votes for 1. Okay, we're going to agree that 1's the correct answer, but let's look at 2, 3, and 4. Okay, do you have enough information to go ahead and treat with BCG? Yes? Raise your hand. Good. The answer to that is no, you don't. Even if it's a conventional urothelial, because it's T1, right? So if you don't feel like the patient needs to go straight to a cystectomy, and I would argue probably not because it's only 2 centimeters, the next step would be a TUR, Re-TUR, a standard of care for T1 disease, and I would give the patient the benefit of the doubt, even though it's micropapillary. That's a way to handle it. You'll see that this turns out how this turns out. Just to let you know, the mouse is a little goofy up here. It could be something I'm doing. Anyway, just a little word about micropapillary. We know a little bit about the molecular features of this. HER2 amplification is common, although HER2 targeted therapy has not really been evaluated in this rate. It does have a very high incidence of occult metastatic disease, very high association with lymphovascular invasion and CIS, all the bad actors that we know about, particularly in T1. So gets a Re-TUR, has a TA high grade, again CIS, again micropapillary, but no lymphovascular invasion. And what do you recommend now? So re-resection, it's only TA, so no residual T1, micropapillary. And I think that if you go down a path of Re-TUR, it's sort of like don't order a test unless you know what you're going to do with the information. Now, you could argue that if it had been T1, probably ought to go ahead and have a cystectomy. But TA, I think that you could give a run at BCG. This is just some data about outcome in micropapillary variant if you use early cystectomy, and upstaging can be quite common just with T1 in general. And then you see here cancer-specific survival seems to favor early cystectomy. So I think that we have a pretty low threshold for moving ahead with cystectomy, and you might treat a 50-year-old different than you would a 75-year-old. Because the 50-year-old has so much more life expectancy at risk. There is an option of bladder sparing, though I have to tell you that I don't think I've done that in a patient with a micropapillary disease. So gets BCG and the 3-month follow-up, positive cytology, but normal cystoscopy. So no visible papillary disease. And what would you do next now? Positive cytology only. How about let's go back and look at those options for just a second. One of the things that's come out in a couple of the clinical trials that we've got open now, looking at both BCG naive patients and BCG unresponsive disease, which I'll talk about, actually I'm not talking about, is when do you biopsy a patient who has a history of CIS? And the field has sort of come around to the fact that if the 3-month cysto is negative and all you have is a positive cytology, to go ahead and treat. And in this case, it'd be 3 weeks of maintenance. The reason for that is if you look at the SWOG 8507, which was the level 1 evidence supporting 3 weeks of maintenance at 3 months, 6 months, 12 months out to 3 years, there was a conversion rate in response between 3 months and 6 months with the 3 weeks of BCG that got the response rate out to 84%. So we're not really acting on a positive cytology alone. Presumably it means that there's still CIS. So this patient went on to get additional BCG, but now he's got a T2 tumor. All right, so the aggressive phenotype is showing itself, and you could say, wow, that happened fast. And yes, it happens fast. This is a very aggressive variant. Fortunately, no evidence of metastatic disease. Now the question comes up, do you do chemotherapy, neoadjuvant chemotherapy? We would, and let me just kind of throw this up there. There's 3 studies that have looked at this, and it's a little mixed. I think the bottom line is that patients with micropapillary disease do respond to systemic neoadjuvant chemotherapy. You could argue that because it's such an aggressive variant, that's an ideal patient to have multidisciplinary combined treatment. So that's the way we're doing that for these patients. And the question remains maybe, and it's really hard to know when you start teasing out or parsing out variant histology in a setting of neoadjuvant chemotherapy because the data the level 1 evidence from 2 clinical trials did not necessarily look at in a pre-specified plan variant histology. So they were included, but also included with pure urothelial. So these patients we would go ahead and treat that way. All right, so that's micropapillary. So this is a patient of mine, 65 years old, colon cancer, remote history. You can see he's got a hostile pelvis, and I can tell you that his Parkinson's disease is reasonably well controlled. So he presents with gross hematuria, has a high-grade urothelial cancer, extensive squamous differentiation, 90%. So the percent could matter. He's got an adequate EGFR for platinum. You can see the detrusor muscle bundles admixed with the tumor, and these are areas of squamous differentiation highlighted by the arrows. So next steps. So we don't have enough data yet to exclude patients with a predominant squamous histology, even if it's a urothelial cancer, from neoadjuvant chemotherapy. So in this case, we treated him with neoadjuvant chemotherapy. And there's some data out there also about trimodal therapy. Jason Estathu, who's kind of one of the, well, Jason's at the MGH where a lot of the data has been generated in trimodal therapy. And this is a summary from a paper that our faculty will recognize. Ross Krasnow was one of our residents who's I think Ross has now finished his fellowship up there. But this is a really nice paper if you're interested in looking at variant histology and the role of trimodal therapy. And you can see that they had a predominant mix of squamous and glandular with small percentages of some of the other variants. And what they showed is that the initial complete response rate was not different between conventional urothelial and variant histology. And this is just the Kaplan-Meier curves comparing pure to variant for both for overall survival and bladder intact disease-specific survival, which is kind of a current hot endpoint that reflects the value of trimodal therapy and bladder preservation. So the guidelines would say to go ahead and give this patient neoadjuvant chemotherapy. And so what's interesting is that even patients with clinical T2, so people ask the question, well, my patient has this guy had a small tumor, completely resected. Does he really need neoadjuvant chemotherapy? If you just sort of set aside the squamous for just a second. And the truth of the matter is that both patients with clinical T2 and more locally advanced cancers benefit from neoadjuvant chemotherapy. So we don't withhold this for really any patient with muscle invasive cancer who has an adequate EGFR and no comorbidities that would otherwise prevent them from getting platinum. Now here's the really interesting paper that sort of has turned this a little bit upside down. So SWOG 8710 was the randomized trial of 3 cycles of MVAC plus cystectomy versus cystectomy alone, one of 2 clinical trials that provide level 1 evidence supporting neoadjuvant chemotherapy. And so Ed Messing and one of his residents went back and asked the question about variant histology. The hypothesis was that the outcomes would be worse with variant, thinking that if you had a high proportion of squamous or adeno that it wouldn't respond. And it turns out the punchline is that it was completely the opposite, that the patients with variant histology actually had better outcomes compared to conventional or pure urothelial. That's hypothesis generating because it wasn't a pre-planned analysis in this clinical trial. So I think it just sort of contributes to a mixture of evidence and doesn't really change the recommendations. And you can see that both the AUA and the EAU guidelines reflect the fact that we can't really select patients out at this point who are otherwise candidates for neoadjuvant chemotherapy. So this guy had some necrotic tissue that's still, and some viable tissue still present, and he actually was and is a pretty healthy guy. So we went ahead and did a radical cystectomy, and you can see that arguably the chemotherapy really didn't do anything. at least in terms of the effect on the primary tumor. Keep in mind that you can have disparate responses in the tumor in the bladder and the metastatic sites. Now, of course, he didn't have metastatic disease, but we're treating on the assumption that there's an increased risk of occult metastatic disease. And then the question here would be, is there any role for adjuvant therapy in a patient with residual muscle invasive disease after neoadjuvant chemotherapy? The answer to that is not yet, but there's a bunch of trials going on with some of the IO agents that will answer those questions. So the last bit that I want to talk about are neuroendocrine cancers, and these are really fascinating. They're uncommon, basically. You might in practice see one a year or one every other year. We see them because they're referred in, and they come in a couple of different varieties. Small cell neuroendocrine would be what you're most familiar with. Looks a lot like small cell of the lung. It also comes in a large cell format. I've seen 2 patients. We treat them just like small cell. There's a well-differentiated format, and then there's this paraganglioma that has a very good prognosis, and I don't honestly think I've ever seen one of those. But here's a patient, 63 years old, but T3 disease, small cell features, adequate, we'll tell you that we would give this patient platinum even though the EGFR is less than 60. Our medical oncologist will go down to about 50. You can see the mass here. This happens to be an MRI, but this is a fairly typical small cell carcinoma. I'll tell you a little bit more about these. So what would be the next steps here? I'm not going to give you the answer. I'm going to ask you to vote. So you've got a T3 tumor, neuroendocrine phenotype. Do you go straight to cystectomy? Do you do neoadjuvant chemotherapy with conventional cisplatin-based chemotherapy? Do you do it with gem-carbo? Yeah, well, we'll get to that. Everybody will have a chance to answer. Gem-carbo because of any concern about his EGFR 55, or do you do etoposide cisplatin, which would be the regimen for small cell? So who would go straight to cystectomy? Raise your hand. Good. Who would do MVAC or GC? Okay. Who would do gem-carbo? Right. So some of you have concerns about his EGFR, and who would do EP? Okay, so EP, etoposide platinum, is the conventional chemotherapy for small cell of the lung, and outside of a clinical trial, that would be the de facto standard that I can tell you that pretty much everybody in the land who doesn't have a clinical trial is using this regimen. So let me just press along here. So a little bit more about the small cell variant. And there are some biomarkers, IHC markers, that the pathologist can use if they have questions about whether this truly represents a small cell. So synaptophysin and chromogranin A. And you can actually measure chromogranin A levels in the peripheral blood. So we do that as well. If it's elevated, it might give us a marker to follow, although a recent conversation with one of our medical oncologists didn't think it was particularly helpful. But it's very helpful to the pathologist. And these are chemosensitive tumors. And what's really quite interesting is that if you have a mixed tumor, which is common, sometimes the EP regimen will wipe out the small cell, but you'll have residual urothelial cancer because it's not an ideal regimen for a pure urothelial. This is just some data from, I believe this is from the MD Anderson group. They've reported clearly on the largest group of patients with small cell neuroendocrine tumors, and you can see kind of the outcome with and without neoadjuvant chemotherapy. So here's with, and here's upfront cystectomy plus adjuvant. Now, why is it such a huge difference between the two? I don't know the answer to that, but part of it could be that one of the challenges with cystectomy is the comorbidities, and some of these patients never really quite recover adequate functional status or EGFR to get platinum-based chemotherapy. So, or the disease progresses very quickly and they don't really have a chance to get treated. So these are especially a group of patients that we want to get chemo in up front in a neoadjuvant setting. So this patient got that, had a complete clinical response, and I think that the tricky part here is, does everybody need to go de facto to a cystectomy? And so radiation is an option. There's a ton of data in small cell of the lung with radiation. There's There's some retrospective series using radiation in neuroendocrine disease of the neuroendocrine cancer of the bladder. And one of the concerns that's raised is that these patients often will have recurrent disease in the bladder despite definitive radiation. But it's a really good option if you're a little bit on the fence about doing a cystectomy on the patient. And then the challenge is that if I would rebiopsy every single one of these patients post-therapy. And if they're cytologically negative and histologically negative, then I think it's a bit of a challenging decision making. So the last two patients that I treated, one lady said, "Forget it, you're not taking my bladder out." And I said, "Okay." And what's interesting is her Re-TUR before chemotherapy was negative, her post-TUR was negative, and she's now probably about 9 months out doing well. And then the second patient, we went ahead and did consolidation radiation, and we'll see how that plays out. So I think that it's not just, okay, cystectomy, it's in this particular phenotype, you want to think about some of the other options. One of the challenging things is in the more locally advanced cancers, there is an increased probability of brain metastasis. And so Arlene Siefer-Radke at MD Anderson has published some data on this and is a fairly strong proponent of doing prophylactic brain irradiation. I don't know that in the more locally advanced tumors, I don't know that that's sort of been adopted by other centers, but it's certainly out there and something that is unique to small cell of the bladder. And so the outcome, this patient had residual PT1 disease, and that, like I said, that's not unusual to have residual urothelial. And this patient obviously has had a good outcome following this type of therapy. So the last two slides are just sort of algorithms. And this is from, it actually looks like Dan Willis, so that's another MD Anderson paper. And credit to them because they have the largest volume of patients with this particular phenotype. And so let me just point out a couple of things. So conventional urothelial with some of the more common variants are going to get neoadjuvant chemotherapy. Pure squamous, pure adeno, rarely would we consider preoperative radiation therapy. Those patients are basically even going to go ahead and get to cystectomy. We've talked about small cell and getting neoadjuvant chemotherapy, and some of these other oddball variants may or may not be good candidates for neoadjuvant, the exception being micropapillary. So thank you.